Right. So, hi everybody. We are happy to be back to have the series of lectures, grand rounds for postgraduate as well as for trainees. We stopped for a while, and we're back to have these lectures. Just some housekeeping stuff before we start. First of all, everybody should be muted. The lecture will last for about almost 15 minutes. At the end of the lectures, we'll open the floor for questions and answers. All questions should be typed. I'll be passing the questions to Professor Francis toward the end, and he's happy to, spend as much time as, as needed for the questions, as we're, interested to have more discussion about your questions and answers. And today, we're glad to have Dr. Francis joining us. Dr. Andrew Francis completed his PhD at Stony Brook in New York, and followed by a postgraduate research in neurobiology at Cornell University Medical School. He obtained an MD from University of Buffalo, followed by a psychiatry residency at Johns Hopkins Hospital. He was the co-developer of the Bush-Francis Catatonia scale, which is the standard clinical and research tool to detect and quantify catatonic symptoms. He is a recognized authority on catatonia, neuroleptic malignant syndrome, ECT, and delirium. Dr. Francis is widely published in these areas and has presented at regional, national, and international medical conferences, as well as serving as an invited lecturer at many academic medical centers. Currently, he's a professor of psychiatry, associate director of residency education, and the Director of Neuromodulation Services at the Penn State School of Medicine at Hershey Medical Center in Pennsylvania. Without further ado, Dr. Francis, the floor is yours.
Thank you very much, Yasir. And I do want to express my appreciation for Dr. Magoob to invite me to give this presentation. And I'm very happy to have him as a colleague here at Penn State, where he's also on the faculty. So greetings from Pennsylvania. This is Hershey Medical Center, where Dr. Magoob and I both work, although we're mostly not in this building. We're at the psychiatric hospital, which is not shown in this picture. So I have no disclosures. I'm a full-time salaried Penn State employee. I will be discussing off-label use of treatments for catatonia. There are no, in the United States anyway, FDA approved. That's the Food and Drug Administration that regulates medicines. There are no FDA-approved medications for catatonia. There is an FDA-approved treatment for catatonia, which is the ECT device. I do have a website, catatonia.org, which has some of the same videos I'll be showing today, plus a variety of other pieces of information. So it's customary in academic talks to start with the European psychiatrists of 100 years ago, figures such as Emil Kraepelin. In the case of catatonia, we go back further. Karl Kalbaum was a German psychiatrist who left academic work and bought a hospital in Eastern Germany, where he became the superintendent for about 30 years. His son, by the way, carried it on after he died in 1899, and that hospital lasted until the Second World War. And while he was there in this hospital, in the previous 10 years, he published a book in 1874 describing unusual cases he'd seen of a newly recognized phenomenon that he named catatonia. And these are consecutive sentences from that introduction to that book. It has beautiful case histories. Dr. Magoob has been reviewing those case histories for one of his projects recently. They have very rich detail, and they have a reality to them that we still see. Patient remains rigid, with a blank stare, devoid of will. This concept of will in German doesn't translate well into English, somewhere between motivation and drive. It can be fully developed or only partial. So catatonia is a graded phenomenon. Impression conveyed is one of mental anguish or shock. We don't hear about that until later when the patients begin to speak, but many of them, not all, have unpleasant mental experiences while they're in that catatonic state. We can talk about that if you'd like. It tends to be persistent, although in some patients it can come and go. It does fluctuate. We have a paper submitted addressing that fluctuation. There may be a diurnal variation as well. And Kalbaum, who's writing in 1874 when medicine and neurology are not very far advanced. So, for example, Broca on aphasia in 1862, Wernicke's aphasia, he didn't publish till later in the 1870s. So Kalbaum, who first described this, notices that it's associated with medical illness. And what he's calling here muscular disorders, we would now call them neurological disorders. And the examples in his era were epilepsy and neurosyphilis. And Kalbaum, of course, made note that it was associated with medical and neurological disorders. So all the important things about catatonia really were recognized by Kalbaum, who first described it. He's a very unappreciated figure in psychiatry. So I became interested in catatonia by accident about 30 years ago. And it started with the resident, whose name was George Bush, not related to the two presidents, who was a resident with us when I was in SUNY Stony Brook in New York, before I moved to Penn State. And we had a patient on the inpatient unit who was catatonic. We struggled with treating that patient. Eventually, we treated her well with ECT. And Dr. Bush approached me and Max Fink, who's 100 years old now, still active and doing writing and correspondence. Max was director of ECT at the time, and he told us, well, catatonia gets better with ECT. You should give that patient ECT, which we did, and she got much better. And Dr. Bush approached me and Max and said, well, this catatonia is so interesting. We didn't know a lot about it. We didn't know how to recognize it. We didn't know how to assess it. And I want to study it. And so I told him, the resident, Dr. Bush, who was a second-year resident, you can't study something unless you have a way to measure it. And so this was his project with our guidance, where we developed the catatonia rating scale. That's freely available. And if you search catatonia rating scale on the web, you'll find it. It's freely available. So we published this as a two-paper set. The first paper described the rating scale, where we got the items on it. Most of them, of course, come from Kalbaum, and a standardized assessment method for assessing the patients. And the second paper in that two-paper set was a treatment outcome. So we prospectively identified a cohort of patients on our inpatient service, 28 patients, and we characterized their treatment response and clinical features. So this rating scale paper has been cited now, it's over 1,000 times citations. It's indicative of growing interest, both clinical and in scholarship research, clinical research on catatonia. And it's the catatonia rating scale has been installed into electronic medical record systems in many places, and it's available in several languages. So we wanted a rating scale that could be used to make a diagnosis and also to monitor treatment, that is to say, to assess severity. So like other clinical syndromes in psychiatry, diagnosis is made by presence of a number of signs and symptoms. And in our research, before we started collecting data, we wanted to be able to capture mild cases. So we set a low criterion of 2 signs present out of 14, the first 14 items on the rating scale. So we're going to make a diagnosis based on presence of at least 2 out of the first 14 items. And then for severity in terms of outcome and treatment, we can rate all 23 items on a 3-point scale. And the rating scale operationally defines all of these items. It's also an anchored rating scale in the sense that it gives you examples, what to score 1 point, what to score 2 points, what to score 3 points. It's anchored in that sense. So these signs mostly came from Kalbaum and other workers. We included the ones most commonly reported in the literature. And in our first 14 screening items, we knew at the time that there was an excited or hyperactive form of catatonia, as well as a retarded or stuporous form. So we included items in this screening list that would capture both of those. Most of these catatonic signs are observational. That is to say, the examiner does nothing except observe the patient. So for example, immobility, stupor, they don't move. Mutism, they don't talk, or they talk very minimally or talk in a whisper. Or they have repetitious movements such as stereotypies and mannerisms. Some of them are elicited, that is to say, the examiner does something to elicit the sign. Echopraxia and echolalia, which I'll show you on the video coming up. Echopraxia is the patient mimics the behaviors of the examiner or someone in the room or someone on the TV. Echolalia is the patient mimics the speech of the examiner or someone in their presence. And some of these catatonic items are by physical exam. So, for example, Gegenhalten, also known as Catatonia, which is an increased tone measured by muscle tone, measured by flexing and extending the elbow. And Gegenhalten is that abnormality of tone where the tone increases during the arc of movement. So diagnosis is going to be made by 2 of the first 14 signs being present to any degree, and then severity rating all 23 signs on a 3-point scale. Later research has shown, and that's perfectly appropriate for psychiatric patients that don't have medical disease or neurological disease. Later research, which I'll talk a little bit about, has shown that in medical populations, especially in an intensive care setting, the best sensitivity and specificity comes from using a higher criterion, not surprisingly. And that research showed that 4 signs out of the 14 rather than 2. It gives the best trade-off between sensitivity and specificity. The DSM-5, the American Diagnostic Code Book, is an advance over prior ones in that it unattached catatonia to schizophrenia, where it had been overly attached by prior workers such as Kraepelin and Bleuler, and prior DSM series as well. In the DSM-5, it's a similar list, 12 items, which are shown with the asterisk, and the DSM concept is 3 out of 12. But for psychiatric patients, there's great overlap between those diagnosed by DSM or Bush-Francis criteria. Here's the DSM 12 items. They define them slightly differently. They don't give exemplars of severity, and some of these definitions are problematic. So, for example, stupor, not actively relating to the environment. Negativism, no response or instructions to external stimuli. To me, those overlap. So I think the DSM list is reasonable for psychiatric patients, and the definitions, however, are better on our rating scale. This is the standardized exam that we developed. It's a systematic way to assess the patient, and the concept here was to help improve reliability by specifying how the patient should be examined. And the idea is that it could be done within a few minutes, 5 minutes, to monitor treatment, which sometimes occurs rapidly with certain treatments. So I'm going to show some examples here of what catatonia looks like, starting with historical examples and then more recent ones. And it's possible that some people in the audience aren't familiar with catatonia or haven't seen it lately. So this first video is an old black and white movie from the early 1930s. And this is a patient who was being examined by Dr. William Bleckwen. Dr. William Bleckwen is considered the father of psychopharmacology in some quarters, because he invented the first treatment for a psychiatric disorder, which was catatonia. And the treatment was a barbiturate, sodium amylbarbital. In the United States, it's known as sodium amytal. And this is from, he's here on the left, the patient's here on the right. And I have narration on this video. And Dr. Magoob, tell me if the sound doesn't come through.
So his arm remains in an upright posture where it was previously placed, and you can see that the examiner moves the limbs and they stay in unusual postures, which may persist for long periods of time. And notice how the whole body seems to be rigid. There's no fluidity at all to the man's posture. He may remain in this unusual rigid posture for extended periods of time. He's not talking to, he's the examiner. He also shows mutism, another catatonic sign. And he's blankly staring, not really engaging with the examiner, who is moving him around. We'll see a close-up of his face here. And you'll notice that he's blankly staring, he's mute, he doesn't engage with the examiner. So it's staring, mutism, withdrawal, rigidity, and catalepsy. Multiple catatonic signs that are all.
So this is a very severe form of catatonia. We still see this today. It looks the same as it was 90 plus years ago when this film was made. Fortunately, it's not that common, but it does exist. You can't miss it if you do see a person having this, and tends to respond very well to treatment, which we'll talk about. There's a hyperactive form of catatonia as well as the stuporous form. And among the hyperactive forms is mannerisms. So mannerisms are repetitious movements like stereotypies are. What is the difference as we've defined them? So stereotypies, the abnormality is in the frequency of it. So for example, rubbing the hands, rocking in posture. These are not abnormal, but what's abnormal is that they persist frequently and intensely. Mannerisms seem odd the first time you see them. They're also repetitious movements. And so this man is showing what I would call mannerisms. This is from the 1940s. It's a little bit later than the previous video. It has no sound. He has a sequence of movements that he makes. So mannerisms often involve parts of the body used for communication, such as the face and hands. So you'll see he's got a sequence. He touches his lapel of his coat. He's moving a piece of paper between his fingers. He touches his mouth and his tie or his lapel. It's a sequence of movements. He's also got grimacing, which is a dyskinetic-like movement of the facial muscles, usually the lower face. In the current era, we would think this might be tardive dyskinesia. This was from the 1940s, however. So he's overall hyperactive. He's got mannerisms, and he's got grimacing. Another hyperactive form of manifestation of catatonia is echopraxia. Echopraxia, here's another video from the 1940s also. It shows a patient and a doctor sitting on a bench outdoors. And you'll notice that the patient, who is the woman, in this case on the left, sits in the same posture as the doctor. She mimics his posture. And then he makes a series of movements and she imitates those movements without being asked to do so. So this is a classic example of echopraxia. So she sits in the same posture with her legs crossed and her hand on her chin. He makes some movements. She repeats them without being asked to do so. Perhaps over-enthusiastically. Perhaps she really has mania in that she's very enthusiastic in mimicking his movements. So this would be echopraxia. Now, catatonia is being increasingly recognized in different populations. And among those populations, and this is something that I've been working to achieve in promoting interest and recognition of catatonia, is catatonia in special populations, such as the developmentally disordered population, and as well with medical populations, which I'll finish with today. So in the developmentally disordered population, there are a variety of children, adolescents, and young adults who can be seen to have unusual behaviors. And increasingly, some of these behaviors can be recognized as being catatonia manifestations. And with that recognition, a treatment opportunity comes forward that wasn't there before, when they were dismissed as, well, this is what autistic children or adolescents do. So these are publicly available from the web, videos posted by families saying, this is our child with autism. I'm going to show 3 examples here today. I can't make a diagnosis, obviously, on a YouTube video that a family posted. But what I can say in the context of this talk, how I would put it is, should a child or a young person or anyone appear in the clinic showing these behaviors, the following catatonic signs could be entertained. So it's in with that frame of reference that I'm commenting about possible catatonic signs in these videos of real people whose family posted them online. So this is a young person. He looks like a teenager or perhaps 12 years old, who's sitting at a table, and the family's in the background. And he's showing some behaviors which, were he in the clinic, could be considered to be catatonia. So his left hand and his right hand and his neck and head are the focus of attention. The family sitting in the background, they make no comment or intervention about his behaviors, which would imply to me that they're chronic, that they're ongoing. So his left hand stays in a posture, both the elbow and the fingers, and the right hand repetitiously moves, as does the neck. So were he in the clinic, we would consider that the left hand has posturing and the right hand has and neck has stereotypies. He's also mute, doesn't speak. The family is observing this, but makes no intervention. Tell me that it's not you. Whoops, let me go back. So now he's going to pick up a spoon and feed himself from the food that's on the table. And you'll see that he gets stuck in the middle of doing that. So this is a catatonic sign, possible catatonic sign in him called ambitendency, where a person gets stuck in the middle of doing something. And you'll see that he does that. Whoops, excuse me. He picks up the food with a spoon, but he gets stuck in the middle. Notice the left hand stays in a posture. He's stuck in the middle. And he gets stuck in the mouth as well. And there's still a tendency for that right hand of the patient. Okay, so were he in the clinic showing these behaviors, we could consider mutism, stereotypies in the arm and the neck, and posturing in the left arm, and ambitendency. Another example, same thing, family posted a video online. This is our child with autism. So it's in the same spirit that I can say that were this person in the clinic showing these behaviors, catatonic signs could be entertained. So this is a young girl, perhaps a teenager or a young adult, and she's got a caregiver here with her. They're in the house. They're going to walk outside the house to the street in front of the house. And she displays a lot of abnormalities that could be considered in the clinic to be catatonic signs. So she has no interaction whatsoever with that caregiver. She holds her right hand in what is likely a posture. So she has withdrawal and posturing, likely. Once she gets outside, she rubs her hands together, which would be a stereotypy. It's not unusual to rub your hands together, but she's also walking in a circle, which would be a mannerism because it looks odd the first time you see it. Again, she has no interaction with the caregiver. So it would be withdrawal, stereotypy, mannerisms, and mutism were she in the clinic showing these behaviors. Third example, same thing, family posted a video online. This is our child with autism. He appears to be much more severely affected because he's wearing protective gear. So he likely has some sort of self-injurious behaviors or injures himself in some way because he has the protective gear. Same thing, he's showing behaviors which, if he were in the clinic and showed these behaviors, could be considered to be catatonia. So you'll see he's got a sequence of movements that he makes, which would be mannerisms. He also has some transient posturing in the fingers and in the arms. He may have staring. It's hard to show on the video to be certain about that. So it's a mixture of stereotype movements, mannerisms, posturing, staring. He's also in constant motion without let up, so it's a mild form of excitement, were he in the clinic showing these behaviors. So the reason to consider looking at behaviors in the developmentally disordered population, such as autism or intellectual disability, is that recognizing that these could be catatonia implies some opportunity for treatment, rather than sort of dismissing it that these children and adolescents have these behaviors and that's how they are with autism. So that's kind of a mission I've had in recent years to do that. There's an uncommon form of excited catatonia, also known as manic delirium or catatonic excitement. And this is police footage of a emergency medical service police operation. And they went to the house, apparently, of an agitated person. This is also online on the web. It's from an EMS, emergency medical service training video. And what you see here is someone who was very agitated, perhaps from drugs, perhaps from mental illness. It's not clear. Were he in the clinic showing these behaviors, catatonic signs could be entertained, which are shown on the video. So he's quiet and has a blank stare. But of course, they're holding him down as well, but they're not holding his head. So this could be mutism and staring. Perpetuation is repeating, it's repeating, it's repeating.
It's okay.
Please,
Don't fight.
Please, and I tap my hand, I fought. Please, and I tap my hand, I fought. Please, and I taught.
We're gonna get you to the hospital.
Please, and I taught.
Relax.
Please, and I.
He's very hyperactive.
Yeah.
He may have a
I'm to the bus, come on, I'm to the bus, come on. I'm to the bus, come on, I'm to the bus, come on.
looping sound.
I'm to the bus, come on, I'm to the bus, come on.
Nobody's. Just relax. Lay your head back and relax, Tim. Tim, lay your head back and relax. Just, we're good. Tim, you're all right.
So that sound kapush could be a manneristic form of speech. So these are small segments of a longer sequence, but people have excited delirium may in fact have catatonic features. So actually, in one of our studies we did when I was in New York at SUNY Stony Brook, we actually looked at, in our psychiatric emergency room, we screened a couple hundred patients for catatonia. And what we found was that agitation, as measured by the Udofsky agitation scale, was a risk factor for catatonia by about 4 times compared to non-agitated patients. So there's more videos on my website, and at the University of Rochester in New York, Dr. Mark Oldham and his colleagues have set up a whole module of catatonia training based on the Bush-Francis scale with instructional videos of how to do the exam, exemplars from an actor. One of the residents acted out the catatonic signs, and there are actually pre and post testing. So it's a very good site for learning more about catatonia and becoming proficient in recognizing it. So is catatonia a relic of the past, or is it something that still exists? And the DSM-5 eventually did a fairly good job on catatonia in terms of giving us a code and unattaching it from schizophrenia. So that diagnostic code, which is an ICD code as well, F06.1, it can be attached to other psychiatric illnesses and medical illness, which is a major advance. But when the DSM-5 committees were first meeting, their original thought was that catatonia doesn't exist and didn't need a code, diagnostic code. So this is a paper we wrote to try to influence the DSM-5. And we reviewed 20 years worth of prospective trials looking at the prevalence of catatonia among psychiatric inpatients. These are hospital patients. Here's our study, Bush et al. 96. We found 7% of inpatients had catatonia. Most of the later studies used our rating scale. And on average, 20 years worth of prospective studies, different ways of defining it. For example, roughly 9% of psychiatric patients on a hospital setting will have catatonia. So it's there. And importantly, most of the patients will have mutism, which is to say they don't speak at all or speak very little. And most of them will have either negativism or withdrawal. And withdrawal means they resist interacting with they don't interact with the environment. And negativism means they actively resist attempts to engage with them. So most of them will have mutism and either negativism or withdrawal, which means that they don't engage in behaviors or speech that allows you to make an additional diagnosis. So people who are presenting with catatonia, if it turns out they have a psychiatric illness, it's most commonly bipolar disorder. It can be schizophrenia, but it's not that common. And a variety of medical conditions, metabolic disturbances, neurological disturbances can present with catatonia. So the point was that patients will be encountered where all you know about them is that they're catatonic and they need a code to guide treatment and also workup. And maybe the DSM listened to us. What about medical populations? How common is catatonia in the medical population? That is to say, patients in the hospital setting, medical part of the hospital, not the psychiatric hospital. It's actually not well studied. So these first 2 studies said between 5 and 8%. However, those studies were examining pieces of paper, not patients. They were examining the list of patients seen by the Psychiatry Consultation Service, which provides consults to the medical hospital. So they were examining the pieces of paper of the consults that we did, how many turned out to have catatonia. This third study was done in Mexico and found a rate of 3%. That study actually examined the patients in the hospital. However, it was a hospital that tends to favor neurological patients. which may be a higher rate. So we don't actually know what is the true prevalence of catatonia in medical populations. Treatment in our study, there had been a few case reports and case series about lorazepam and to some extent other benzodiazepines treating catatonia, but there hadn't been systematic studies with quantitative outcomes, which we attempted to do in that paper. So we did a intravenous dosing if we could, and we gave lorazepam in doses up to 8 milligrams a day for 5 days. It was a short-term trial. Success was they no longer met criteria. Our criterion was 2 signs being present, and failure was they persisted with catatonia or got worse. So these were patients who received intravenous lorazepam for their catatonia. And what's shown here on the y-axis is the score on the catatonia rating scale. Each of the 23 items rated on a 3-point scale. The maximum would be 69, 23 times 3. Typical patient in a hospital setting is usually somewhere between 15 and 25. It's rare to be above 30, but it does happen. So this was their score at baseline when we found them. And then they got 1 dose of 1 milligram of lorazepam, and they got a second dose, a 2nd milligram. So 2 milligrams total, 10 minutes time total. And within that 10 minutes, the scores dropped on average less than half of what they were. Some patients, their catatonia resolved, some it didn't change, but there was a spread of improvement. This became the basis of what's now known as the lorazepam challenge test, which is used to confirm diagnosis and start treatment. So in our sample, our prospectively identified sample, what were the predictors of response to lorazepam? Basic demographics and also severity of catatonia didn't matter. It didn't matter whether it was psychiatric related or medical related catatonia. And this has all been confirmed in later studies. A mild case, a severe case can still respond to catatonia, but demographics don't seem to matter. Not surprisingly, the duration of catatonia was a predictor of less response. It's not surprising in medicine that something that's been going on for a long time is harder to treat. Importantly, for clinical purposes, if there was a response on the first day with lorazepam, that was predictive of ultimate good response. So some patients may need high doses of lorazepam to treat their catatonia. Doses of 20 to 30 milligrams can be used, and Dr. Magoob and I have used such doses in some patients. And dose didn't seem to matter, although in retrospect, this was underdosing. We've now learned since that some patients require high doses of lorazepam or perhaps other benzodiazepines. The patients who failed lorazepam were able to have ECT. This was bilateral ECT. We stopped lorazepam. In retrospect, a later study, we discovered that low-dose lorazepam is synergistic with ECT. So nowadays, when we do ECT for catatonia, we keep a small amount of benzodiazepines going. And even patients here who failed lorazepam tend to get better very quickly with ECT. One patient was atypical in that he only had catatonia, no other mental disorder. It took longer to recover. Catatonia, if it's severe and persistent, has many medical complications and is potentially fatal. Aspiration pneumonia, swallowing reflexes are disturbed, pulmonary embolism, and other embolic phenomena from not moving, rhabdomyolysis from muscle breakdown. So all of these medical complications have been reported. So it's important that when catatonia is severe and persistent, that it's recognized and treated. And if it can't be treated promptly, efforts made to reduce these complications are warranted. So I've been involved in many studies of catatonia over the years. The first one's just as I've shown. Is there a question?
I have a question.
Yeah.
Regarding the treatment of catatonia. For example, in our situation, sometimes lorazepam may not be available. Can I use other form of benzodiazepine, such as diazepam intravenous injection or so?
So the question is other benzodiazepines. There's not as much clinical experience in literature with other benzodiazepines. I do realize lorazepam is not available in some parts of the world. There are some reports of diazepam and also midazolam treating catatonia. They don't seem to be as robust a response. However, there aren't good studies on that. So some parts of the world don't have lorazepam. Lorazepam does seem to be superior to other benzodiazepines in general, but there are reports, small studies, cases of diazepam and also midazolam, which are both available intravenous. And also midazolam can be given intramuscular. So we've looked at, we'll have further questions at the end. We've looked at prevalence of phenomenology, treatment response, subtypes, discrimination from other motor syndromes. We looked at an elderly population with catatonia who had been long exposed to antipsychotic drugs, who had Parkinson's, either idiopathic or drug-induced, as well as dyskinesias. And we assessed them for other motor syndromes. And the bottom line was that catatonia can be told apart from Parkinson's, tardive dyskinesia, akathisia, from these other motor syndromes. We published on looking at neuroleptic malignant syndrome as a drug-induced form of malignant catatonia. Malignant catatonia means that catatonia associated with severe autonomic symptoms, things like fever, hypertension, tachycardia, diaphoresis. And laterally looking at catatonia in medical populations, including in particular delirium, which is what I'll finish with for the rest of the talk. So I was an inpatient psychiatrist for most of my career. Lately, I've been working in neuromodulation and ECT. And I also did ECT for many years as well. And I would at times cover the consultation service. That is to say, the psychiatry service that provides inpatient consultation, psychiatric consultation to the medical surgical patients of the hospital. And I was aware that we would see catatonia in the ICU and setting and also the medical floors. We had a geriatric psychiatry fellow, Antonio Lopez Canino, who was on his consultation rotation, and he called me up and said, hey, we have 3 right now who are in the ICU who have both catatonia and delirium. And so we decided to publish this and be provocative. We published this paper hypothesizing a new type of delirium. So there's delirium with and without psychosis. There's delirium with and without agitation. And so we were provocative to say, is there such a thing as delirium with and without catatonia? So we had 3 patients in front of us. We did a literature search as well. So in the literature search, research on delirium, much of it is characterized by looking at the clinical phenotype. And delirium is often categorized into motoric subtype, into a hypoactive and a hyperactive form of delirium. And there's a variety of literature on this. And that these 2 forms of delirium differed in their causes. So for example, alcohol withdrawal is likely to be a hyperactive form of delirium. Certain metabolic delirium, such as uremia or liver failure associated delirium, are likely to be hypoactive forms. They differed in some studies in terms of their treatment and prognosis, and there were even some biochemical differences, which is cited here. A melatonin metabolite seemed to be different between hyperactive and hypoactive forms of delirium that changed with treatment. So when we look more closely at how different research groups had defined this hypoactive form of delirium, this is what we found. So these are 5 different research groups that had attempted to define the hypoactive form of delirium. So for example, the first one, confusion assessment method, that's Dr. Ellie from Vanderbilt University in Tennessee, in Kentucky. I think it's in Tennessee, actually. And his group had defined a method of assessment of delirium called the confusion assessment method. So his definition of hypoactive: decreased motor activity, sluggish, staring, staying in one position, moving very slowly. And it seemed to us this could map onto catatonic signs listed there: immobility, staring, and posturing. The third one listed, Memorial Delirium Assessment Scale. That's Dr. William Breitbart at Sloan Kettering Hospital, which is a cancer center in New York City. Reduced or slowed movement, rarely moves, rarely speaks, is catatonic. That's actually in their definition. So it looked like these definitions of hypoactive delirium could map to catatonia. And when we looked in the literature, as well as looking at these definitions, we looked for cases where it could be confirmed that they met criteria for catatonia and delirium on the same day, as well as the 3 cases we had in front of us. So we had 13 cases from the literature. We had 3 cases in front of us from our own service, 16 total patients, and all of whom were catatonic and delirious on the same day. And we looked at the features of the catatonia, which they showed. So they showed the very typical stuporous or retarded form of delirium, of catatonia. That is to say, mutism, withdrawal, posturing, immobility, and staring, just like those old videos that I showed you from the 1930s. So it was a suggestion that catatonia and delirium could coexist, which, by the way, the DSM-5 says can't happen. So you may ask, well, how is it possible to assess delirium in someone who is catatonic? Because they often don't speak or are very withdrawn. Well, it is possible, and people have done it. The right-hand panel in this slide shows the DSM-4 criteria, which is what we used in our study, first study anyway. Disturbance of consciousness with reduced ability to focus, sustain, or shift attention. It's not necessary to talk to assess that. Change in cognition or perception that is not better accounted for. So perceptual disturbance, they could be having visual hallucinations and show behavioral evidence of that by grabbing into space for unseen objects. Short period of time and evidence of a cause. So all of those things could be done in a patient who has catatonia. Can be challenging, of course, but it has been done. And in fact, people who have mutism from catatonia sometimes do talk at times. The left panel shows the DSM-5 criteria for delirium. Disturbance in attention, which would include reduced ability to focus or sustain attention. And you don't need to talk to do that. The patient does not need to speak. Disturbance develops over a short period of time. And additional disturbance of cognition, which could be visual spatial ability. So visual spatial ability could be dyspraxia or apraxia, which you could assess potentially in a patient that's not speaking or speaking minimally. So it is possible to diagnose delirium in somebody who is catatonic. It can be challenging and difficult, but it can be done and has been done many times. So I tried to get our consultation service to do a systematic study of delirium, catatonia and delirium on the medical floors, to no avail. They resisted my efforts. However, other people were inspired by that paper, and one of them was Sandeep Grover in India, who's at a teaching hospital. So this was not a true prospective study, but it's a systematic study. So they looked at consecutive referrals to the consultation service from the medical surgical part of the hospital, not psychiatry, medical patients. And those who were confirmed to have delirium by clinical grounds, DSM-5, as well as by research grounds using the DRS-98, which is the Topaz Delirium Rating Scale, where it's possible to make diagnoses from the rating scale, like the Bush-Francis or the Beck or other scales. And catatonia was assessed by Bush-Francis, which is a low bar, 2 out of 14, and the DSM-5, a little higher bar, which is 3 out of 12. Catatonia was present in 13 to 32%, depending upon what criterion was used. And importantly, the severity of the delirium correlated with the severity of the catatonia. So this was confirmation, better confirmation now that catatonia and delirium could coexist. No treatment outcome was provided in that paper. Around this time, I went to the psychosomatics, now called Consultation Liaison Conference. I've been going for years, and I met Jo Ellen Wilson, who's at Vanderbilt, where Dr. Ellie is, who does delirium research. And she was a psychiatrist who'd done residency and a consultation fellowship, and she was inspired by that same paper we published on delirium and catatonia to do a systematic assessment and a prospective one. So Dr. Ellie conducts large multi-center trials on delirium outcome. And Vanderbilt, of course, is a site for these, as well as other hospitals in these studies. So what Dr. Wilson and her colleagues were able to do is delirium ratings on these patients who were in the delirium outcome study. They did catatonia ratings, I should say, on those patients in the delirium outcome study. So these were patients middle-aged and older who entered the ICU with neither catatonia nor delirium, usually for sepsis or respiratory problems. And then they were followed. Some of them had treatments and biological outcomes were being studied. And this was published, I became a outside collaborator with her and her group. And this was published in a critical care journal a few years ago. The first wave of the study had 136 patients. These are people who are not delirious and not catatonic entering an ICU and then prospectively followed. So not surprisingly, 42% had delirium. Delirium is common in ICU settings, but 30% had both delirium and catatonia. Catatonia here was defined by the DSM-5, which is 3 out of 12, and delirium was defined by the CAM-ICU method. No treatment was provided here. So this is a prospective blinded confirmation that delirium and catatonia can coexist. We don't know yet what the implication is this has for the outcome of delirium or for treatment. But there are some hints now with respect to treatment, and the evidence is accumulating, but still weak. And I'll describe what that evidence was. This was a study done from the University of Chicago by Dr. Cooper and his colleagues. They were, in this paper, attempting to address what about patients on the medical services, medical inpatients who are catatonic, but nobody knows they're catatonic. What happens to them? So what they were able to do is use the electronic medical record to find people who are catatonic on the medical floors by searching the electronic notes for words like posturing, words like immobility, words like stupor. And they found 54 patients who met DSM-5 criteria. DSM-5, again, is 3 out of 12. So these are medical patients, not psychiatric patients, who met criteria for having DSM-5 catatonia. Of those 54, 29 appear to also have delirium based on DSM-5 criteria. There was naturalistic treatment of some of them. So of those 54 patients, 29 had lorazepam, not the same 29 who had delirium. And this is the response to lorazepam. Now, this was in a chart review retrospective study. So it's an impressionistic response to treatment. The doses were in the range of 1 to 1.5 milligrams typically when I spoke to the authors about this. And because it was a chart study, it wasn't systematic data, there was an impression gained from reading the progress notes that the patients improved overall. And what improved? It appeared that both the catatonia and the delirium improved. They were globally better. So this, what's shown here is a total number of patients on the y-axis. So this leftmost column labeled all, 29 patients out of the 54 got lorazepam, of whom 83% got better. So this is typical response to lorazepam overall. Now looking on the right at the last two columns, this is now the same 29 patients divided up into whether they had delirium or not. So 17 had delirium, 12 did not, of those 29 who got lorazepam. Not all the delirious catatonic patients got lorazepam. So the presence of delirium, still 71% got better. And again, this is a retrospective study, but there was a hint or a suggestion that perhaps lorazepam could be used. We normally avoid lorazepam and delirium and also other benzodiazepines. But perhaps it could be useful in this setting. This now is a better study. This was a prospective naturalistic study done at SUNY Stony Brook by my and Dr. Magoob's colleague, Charles Mormondo, when he was a resident there. He's now part of the faculty, and I was a collaborator as well with this project. So this is medical patients being screened systematically for catatonia and delirium. Every patient admitted, 700 plus patients were screened. And 15 were identified who met criteria for catatonia, which was a high criterion. It was 4 signs out of 14 on the Bush-Francis, 4 signs present. And the delirium was assessed by the CAM-ICU method. So of these 15 patients, 7 got lorazepam and 8 did not. This was naturalistic studies in the dose of about 2 or 2.5 milligrams per day. This was a very elderly population on the medical service. They all had delirium, and now we have quantitative data. So their catatonia score on the 23 item was 14 versus 11.4, not significantly different. On the left panel on the bottom, this is now their Bush-Francis catatonia score. So the blue bar on the left is score at the beginning, and this is score after lorazepam. It dropped by more than 2/3. And the presence of delirium, 100% had delirium, which is on the right axis here, and only 40% had delirium afterwards. So both catatonia and delirium improved with lorazepam. This is now naturalistic but prospective with quantitative data, so the evidence is getting better. The right-hand panel on the bottom, these are the patients who had delirium and catatonia both, but never got lorazepam. Their catatonia score didn't change during their hospital stay, and their status of having delirium didn't change during their hospital stay. So this is better evidence that perhaps lorazepam can be used for the treatment of catatonia when it exists with delirium. So I'll finish here, so there's time for some discussion, and I think there's things coming in the chat. Catatonia is a distinct syndrome associated with morbidity if severe and untreated. It's important to recognize it, and it's important to look for it in delirium because it may or may not have a prognostic implication. We don't know that yet, whether it's good or bad, so to speak, to have delirium with and without catatonia. Also looking in special populations, such as the developmentally disordered population of children, adolescents, and young adults, because if recognized, catatonia often responds to treatment. We don't know the details of how often it responds, but we have many cases, and many cases have been published of dramatic improvements of severe behavioral disturbance that are really life-changing in these individuals. I might add that dementia is the new frontier for catatonia. This is coming. Often responds to treatment if diagnosed. Catatonia and delirium can coexist. We don't know the implications with respect to treatment or outcome as of yet. There is some hints from the literature that low-dose lorazepam may be useful. We don't know that for sure. Other agents such as memantine or amantadine are possibly being used or could be used for delirium and catatonia. We don't know the answer to that yet. We tend to avoid high-potency antipsychotic drugs such as haloperidol in catatonia because it can make it worse. It can induce catatonia, or it can convert catatonia to a malignant form of catatonia. So I'll stop there, and I hope to have questions and discussion. So as a reminder, my website, catatonia.org, has a variety of information and additional videos of typical examples, as well as the University of Rochester Catatonia website, which can be easily found by a web search. Dr. Magoo?
All right. Thank you very much, Dr. Francis, for the interesting presentation and for the topic itself. We have questions in the chat here. First question. Any abnormal EEG findings of catatonic patients, similarities between some cases of catatonia and complex partial seizures?
So there have been some studies looking at EEG in catatonia. The problem with these studies is that they had a mixture. They're mostly case series kinds of studies or retrospective, and they have a mixture of what you might call psychiatric catatonia and what you might call medical catatonia. And the problem is that in the case of medical catatonia, things like seizure disorder, things like metabolic disturbances, things like autoimmune disorders, things like certain medications, for example, corticosteroids can induce catatonia. Those medical or biological definable precipitants to the catatonia themselves have EEG abnormalities. So in these studies, they had a mixture of psychiatric and medical catatonia, and it's a very complex, inconclusive kind of result. Most of them found, quote, generalized slowing, unquote, non-specific findings. I've listed here a variety of other biological studies on catatonia. It's not well studied, and one of the reasons it's not well studied is that it's difficult to do research on subjects who can't consent. There's a lack of recognition of catatonia as a very good research topic. With respect to the seizures, yes, epilepsy can present with catatonic signs. So there's something called non-convulsive status epilepticus, which looks like catatonia. And you can have partial complex seizures with catatonic reactions, including unilateral. We had a case of a person who had partial complex seizures. She had unilateral catatonia from that side, contralateral side of the body. I'm not sure I'm answering the question about the epilepsy and catatonia, but epilepsy is associated with catatonia. So for a new onset, a new presentation of catatonia, you might consider a EEG and brain scan. The workup of the biological workup or medical workup of a patient with catatonia depends on their history. So some patients have recurrent catatonia, and if in a hospital setting, for example, the same patient comes back with another episode, they may not really have much in the way of a medical assessment. But a new onset catatonia deserves some level of medical assessment, which might include, doesn't necessarily have to include, but it might include EEG, brain scan, potentially even lumbar puncture. A variety of encephalitis, NMDA receptor encephalitis is just one example, can present with catatonia.
All right, thank you. Another question here. This is on catatonia and delirium.
Yes.
When we give benzodiazepines for a patient with delirium, the symptoms can get worse.
Yes.
How do you explain the improvement when it coexists with catatonia? Does it have anything to do with subtypes of delirium or types of symptoms of catatonia?
We don't know enough to know about the subtypes. Most of those patients in the studies that I cited had a withdrawn or stuporous form of catatonia, not catatonia excitement. So most of them had the stuporous or retarded form of catatonia. But with respect to benzodiazepines in treatment of catatonia and delirium when they coexist, we don't know the answer to that yet. As I mentioned, there's only suggestions and hints from the literature. There isn't a good systematic study. There is recently published one systematic study that attempted to prospectively identify catatonia and delirium and prospectively treat it. But the problem with that study, it was from South America at a university hospital. The problem with that study, the lead author is Appiani, Appiani. The problem with that study is that the research team did not control the patients. So many of the patients who had identified as having delirium and catatonia that the researchers wanted to prospectively treat, the treating physician refused to allow the study. So they were not able to capture very many of the subjects they identified as having delirium and catatonia and enter them into the treatment trial. That's a problem because the report that they had was, I think, only 1 or 2 out of 9 improved with lorazepam. The others did not get worse. They do say that, but their catatonia did not improve, nor did their delirium, but they did not get worse. So although that study attempted to be systematic, they failed because the doctors who were responsible for the physicians refused to allow the treatment.
Another follow-up questions again on.
It's an open question. It's an open question. Now, I would point out that I know the audience is from different parts of the world, but in the United States, in an ICU setting, by the time the ICU doctor calls for a psychiatry consult, the patients have typically had benzodiazepines. So it's not like people in the ICU never get benzodiazepines. So if we're going to give a very small dose of a benzodiazepine to a patient who's delirious and catatonic at the same time, it's not something that it would never have happened in an ICU setting. Yes, go on.
That's another follow-up question here. In cases of catatonia with delirium and benzodiazepine use, isn't going to be worse for delirium? The use of benzodiazepine for delirium?
It can happen. So as I mentioned, we don't have good evidence yet. We only have hints. And the one study that's published that tried to prospectively identify this was a failure in the sense that they couldn't get an adequate sample. One alternative to benzodiazepines might be agents which are considered to be NMDA antagonists, one of which is memantine. And we had a case at Penn State. I think Dr. Magoob knew about this case. He wasn't involved in her care. So this is a patient who had catatonia and cognitive impairment, was referred for ECT, but she had severe carotid stenosis, which made us not accept her for ECT. And we gave her memantine. The dose eventually reached 20 milligrams, as I recall, per day. Both the catatonia and the cognition improved with memantine during a time when no other med change was made. And we published this case in the Psychosomatic Journal. In the literature review that we did, there are case reports of memantine, also of amantadine, but in this case, for this paper, memantine, treating catatonia, case reports and case series. These case reports and case series focused on improvement of the catatonia with memantine. However, some of them had sufficient detail or explicit detail that the cognition also improved. So this might be a suggestion that could be tried in the setting of catatonia and delirium coexisting, an agent such as memantine, which is not very likely to make delirium worse, but might improve catatonia. More comments or questions?
Any place for antimuscarinics for treatment of catatonia?
Atropinic drugs?
Antimuscarinics. Yeah.
Okay, antimuscarinic agents would be atropine and related drugs. They're highly likely to make delirium worse. If I'm understanding the question. If the questioner is asking about a pro-muscarinic drug, a cholinergic agonist, such as being used in dementia, that's an open question. No, there's to my knowledge, there's no good evidence that atropinic drugs or cholinergic agonists treat catatonia. I may be misunderstanding the question, because I wouldn't conceive of an atropinic drug, atropine-like drug being used in delirium. So maybe I'm misunderstanding the question.
Another question on hyperactive delirium and catatonia, hyperactive delirium of ICU patients. Could we use the Bush-Francis scale and treat cases with benzodiazepines?
Please do. Please do. And if you have any success or make things worse, I think it should be published. I'd be happy to help people do that. As I mentioned, we know now definitively that catatonia and delirium can coexist. We don't know yet, is this a good thing or a bad thing? In terms of delirium in general does not have a terribly good prognosis. There's plenty of evidence that delirium, at least in some people, can lead to long-lasting cognitive impairments, and perhaps as a risk for early dementia. This is not entirely clear. So we don't know whether the presence of catatonia inside delirium makes things better or worse with respect to prognosis, which might be a reason to treat it. And we also don't know yet how to treat it. There's hints, there's suggestions, but we don't have anything that's really solid and systematic as of yet. When I give talks, I hear from people in the audience, oh, we've given a few people in that scenario midazolam and slow dose and they improved. I say, please publish this. Even if you have 3 cases, it could be a case series which would help move the literature forward.
Shifting gears here, is serotonin syndrome considered as a subtype of catatonia and should be treated as catatonia?
Some authors have claimed that. So some features of serotonin syndrome overlap with catatonia. So some people have advocated that this be recognized as a catatonic variant. I haven't seen enough of it myself to know, but that case has been made in the literature.
And questions on treatment here. What is the proper dose of lorazepam to start with for treatment of catatonia, and after how long better to do a reassessment, and for how long till when we shall keep giving lorazepam for assessment for treatment?
For treatment? Okay. So the dose depends upon the clinical status of the patient. So if it's a very vigorous young adult, you might start off with a few milligrams a day. If it's a frail elderly person, you might start off with a fraction of a milligram of lorazepam or equivalent of other benzos. benzodiazepines. So the dose would depend upon the severity of the catatonia and the medical frailty or the medical stability or the medical instability of the person being treated. So catatonia and delirium, the population to be found in intensive care units, for example, tends to be elderly and medically complex, sometimes medically frail. And so those patients, if they're going to have a trial of lorazepam, it would be a low dose, perhaps even less than 1 milligram to start. How long to keep the treatment going? It depends on how the catatonia can be understood. So if the catatonia is being understood as a medical catatonia from a definable precipitant. So for example, someone that's getting high-dose corticosteroids for some medical issue can have a catatonic reaction. That catatonic reaction is likely to resolve, perhaps even on its own, with cessation of the corticosteroids, if that can be medically done, or with a brief period of treatment. Similarly, with certain metabolic disturbances, if those metabolic disturbances can be corrected medically, sometimes the catatonia resolves or only needs a brief period of treatment. So catatonia, when it exists in the developmentally disordered populations, tends to be quite chronic and often needs maintenance treatment. And from our clinical experience and also from the literature, such patients may remain chronically on benzodiazepines with or without actually ECT as well, even maintenance ECT. And persons who have a mood disorder who are catatonic, their catatonia tends to occur in mood episodes. And so they tend to not need chronic treatments for their catatonia. Not sure that answers the question.
Next question here. I have a patient with schizophrenia who has lower limb edema because he refused to sleep on his bed without obvious reasons for months. Could be considered as a catatonic feature?
Can the questioner say where he slept if he didn't sleep in his bed? Did he sleep standing up?
Or this is not orthopnea too for somebody with a heart failure?
Say it again.
Or if it's not orthopnea for somebody with a heart failure?
Yes. So I mean, lower limb edema has a medical differential, but it is true that so if I understand the question, he showed a behavioral abnormality of not sleeping in his bed and sleeping somewhere else.
There's a follow-up here. It's on the chair and the patient is medically cleared.
Okay. So that could be a mannerism. Sometimes there's reports of people sleeping backwards in the bed. So in the United States, at least, there's orientation to a bed as to part of it next to a wall and a pillow that defines the head of the bed. I've seen examples, and I think Dr. Yasir has seen them also, of people who sleep backwards. They deliberately sleep with their feet at the head of the bed. So this could be viewed as a mannerism. So my answer is, what else can be shown to be present? So that patient should be assessed with a systematic assessment, such as the Bush-Francis scale, to see do they have other catatonic signs. But even if they had only that, I would consider a trial of benzodiazepine, because this is medically compromising this person. Chronic edema from not lying down, if it can't be medically corrected or explained, is adverse for health. So it warrants efforts to treat. And by the way, that would be a reportable case. So the author, if they do a treatment, should try to be systematic with a rating scale, whether it fails or is successful. That would be a reportable case. You do agree, Dr. Makub?
Yep.
So reach out to us and we'll help you publish that for the questionnaire.
Okay. Next question here. How can we differentiate between neuroleptic malignant syndrome and malignant catatonia?
Well, so there's a phrase here in the United States called lumpers and splitters. I'm more of a lumper. So to my way of thinking, malignant catatonia, neuroleptic malignant syndrome, catatonic excitement, and manic delirium, or excited delirium, these are all various names for the same thing. In science, you can't prove two things are the same, but you can fail to find a difference. So in our studies, when we identified people who met criteria for neuroleptic syndrome, including strict research criteria, turns out they had catatonia. When we identified people with catatonia, some of them have neuroleptic malignant meet criteria for neuroleptic malignant syndrome. Lorazepam can treat both. ECT can treat both. There are certain biochemical abnormalities that are seen in both. So studies tend to show not much difference between those entities. So I'm more of a lumper than a splitter. I'm not sure that answers the question.
The next two questions, actually, they're closely related to each other. They're asking for a comment. I'm going to combine them together. Asking for a comment on the role of clozapine and aripiprazole for the treatment of catatonia.
So in the treatment of catatonia, if it can be medically addressed, if a medical cause or a medical factor is found, correction of that medical factor is paramount, or a neurological. So, for example, they have a subclinical seizures or partial complex seizures. So if a medical or a neurological basis can be found and corrected or addressed or treated, that's of course of principal importance. But assuming that a person is catatonic and there isn't a medical basis identified, there are two treatments which are absolutely first line. And those two treatments are lorazepam and ECT. Everything else is second line. So there's a variety of secondary agents. Memantine would be one, amantadine would be another. There's a conflicting literature on atypical antipsychotics. There are case reports of catatonia improving with atypical antipsychotics, and there are case reports of catatonia worsening and converting to a malignant form of NMS/malignant catatonia with atypical antipsychotics. And among the atypical antipsychotics, some seem better than others. There's a small trial, actually, of risperidone, small prospective trial, 8 subjects, randomized assignment of ECT versus risperidone. The ones with risperidone did improve, but not as much as with ECT. These are people who failed lorazepam. The author is Girish, G-I-R-I-S-H, and Gill, G-I-L-L, if people want to look that up. It's a small prospective study. The clozapine, olanzapine, aripiprazole, those are probably the atypical antipsychotics that have most support in the literature, but I wouldn't use them as first line. I would use a benzodiazepine to try to relieve the catatonia as much as possible. You might consider, once you relieve the catatonia, if the patient shows psychotic symptoms, to add cautiously an atypical antipsychotic. There isn't good literature to guide us on this, however. Keep the benzodiazepine going and watch closely for extrapyramidal or catatonic signs. There's a couple studies that show a blood test, which is serum iron, might be useful in this scenario. That is to say, measuring serum iron, if it's low, that's a risk for conversion to a malignant catatonia from antipsychotic agents. Go on.
All right, next question. How to improve the skills for recognizing atypical presentation of catatonia, so to decrease missing these cases?
Well, I would refer you to one thing is invite me to give a talk. And the other thing is the University of Rochester. If you search University of Rochester Catatonia website, you will find those training materials. So there is a video explaining how to use the rating scale. There are video examples of all 23 items on the catatonia scale. There's a test. There's a multiple choice and a video test that people can take. They can complete the training materials and repeat the test and see that their skills improved. So these are the best ways that I'm aware of to improve skills at recognizing catatonia. And I would also comment that it tends to become progressively better the more you see it.
Next question. Do we have any bedside tests that can help we can use to differentiate between catatonic schizophrenia and delirium?
Well, history is one. So if you know something about the history of the patient, schizophrenia tends to be a long chronic thing. a long chronic illness didn't start yesterday, but delirium might have started yesterday. So one would be duration of onset, of how abruptness the onset is. Schizophrenia is classically a insidious illness where it's progressive over time. It emerges over months or years, whereas delirium tends to emerge over hours or days. So if you know something about the onset of the condition, would be one thing. Delirium tends to fluctuate. There's some evidence that catatonia fluctuates, but perhaps not as much. Delirium tends to be associated with definable medical abnormalities, electrolyte disturbance, infection, a whole variety of things that people in the audience must be aware of. People with catatonia don't usually have those things, or they can, but they can be identified. And the schizophrenia is characterized by psychotic symptoms, and catatonia is usually not. So there's a variety of things. So if presented with a patient that you know absolutely nothing about, it can be more challenging. But usually the patients come with some sort of historical information or old records or information from the family as to the course of illness. I'm not sure I'm answering the question.
I think you did. All right. I think this was the last question we have. I will stop the recording.